in which case they're a transient responder and it's time to do more resuscitation. Or did they not respond at all? A bit more on the rare side up front, especially with a trauma patient, but I guess it happens. If they didn't respond at all, then, try something else, but then really start asking, am I missing something? And so one of the common things in trauma that you could miss as a other alternate mechanism of shock would be obstructive shock. They have a tension pneumothorax or they have a hemothorax and cardiac tamponade. And that's actually happened to patients of mine in the hospital, cardiac surgery patients or cardiac intervention patients, where we thought they were in cardiogenic shock. We're doing all the right things for that, and they're not responding. And we throw an ultrasound probe on them, and the small pericardial effusion has now become large and it's compressing, cardiac chambers. So non-responding to shock, and I know this is a talk more about labs, but you use labs to make clinical decisions. And so is part of, non-responding to interventions should trigger you to think about, am I missing a mechanism? Am I missing something?
Absolutely. I guess especially with adding Bi-Carb to it, how much of a response do you expect to see?
I would expect to see the next pH, unless they're actively exsanguinating, which, I hope they're not. I hope you've either, compression of compressible hemorrhage and that they don't have like a major interior arterial bleed, which would be catastrophic. But let's say absent those two things, I would expect to see the next pH above 7.2. We have these patients come in cardiogenic shock mostly, but we have some hemorrhagic shock as well, postoperative bleeding, post-procedural bleeding, and their pHs are in the sevens, low sevens, 7, and we can get them up in the 7.3s with just one round of Bi-Carb.
Okay. How long would you expect the Bi-Carb to last?
A good question, because it's not just the Bi-Carb, it's their own metabolism's response to the resuscitation. So, you almost never give Bi-Carb in a vacuum. You're always doing it as part of something else. You're giving blood to resuscitate hemorrhagic shock. You are putting them on an inotrope to help the heart squeeze harder in cardiogenic shock. That inotrope, epinephrine for us as first line, is not going to work very well when the pH is 7, but if you get it over 7.2, it's going to start working. So it's really hard to characterize how long that Bi-Carb is going to stick around. I would, and a lot of that really depends on, because it's really part of a composite picture of how sick your patient is physiologically. And if they are a responder or a non-responder. Hard to say.
So obviously we beat, I think, pH to death. Now there's a bunch of other aspects, like you mentioned, ionized calcium. We have with the CG8 test, you have your ionized calcium, you have your H&H, you have all your blood gases. Are there any real value in getting those?
The biggest, I think, asset of the additional labs would be to help you manage your ventilator with the blood gases, right? H&H, I'll get some flack for this, but I honestly don't really care about an H&H. In a bleeding patient, I don't need a hemoglobin to tell me they're bleeding. I need an ultrasound to tell me they're bleeding, or I need open wounds to show me, is it a venous bleed or an arterial bleed? And if it's an interior bleed, I need an ultrasound to diagnose it. And then I need serial ultrasound exams to tell me, is it getting bigger? And I think it's one of the biggest misconceptions in trauma and hemorrhagic shock resuscitation. I think the trauma community is really good about this because they understand that hemoglobin is something that equilibrates with volume shifts, but they're about the only community that does. Everybody else is like, the hemoglobin's fine, they can't be bleeding. And, you've got